Hi, everyone. Welcome to another episode of Darshan Talks. I'm your host, Darshan Kulkarni. I'm here with my co-host, Murthy, who's lying down. Uh, it's my mission to help you trust the products you depend on. So, as you know, I'm an attorney. I'm a pharmacist, and I advise companies with FDA-regulated products. So if you think about drugs, wonder about devices, consider cannabis, or obsess over pharmacy, this is the podcast for you. I have to specify, I'm an attorney, so it's not legal advice, and this is not legal advice. Our guest today is a physician, but he's not giving clinical advice. I do these podcasts because they're a lot of fun and because I know I find myself learning something new each time. So it'd be great to know when someone's listening. So if you like what you hear, please leave a comment, please subscribe. Please ask questions while we're talking as well. And if that conversation seems to appeal to you, please share. If you want to find me, please reach out to me on Darshan Talks on Twitter, or just go to our website at darshantalks.com. Today's podcast is going to be really interesting because we're going to talk about this idea of decentralized care delivery. And it's a term that I have never heard until earlier today. And I am excited to hear about it because it seems to have so many implications. I mean, I think I've seen the impact, but never heard the term. So if you are in the life sciences and you're going, how do I meet my patient where they are? You should care about today's discussion. Our guest today is really interesting. He is the CEO the Chief Medical Officer at Bluestream Health. And if you look at his LinkedIn profile, you just realize just how well qualified he is. Our guest of today, Sandeep Pullam. Hey, Sandeep, how are you?
Hey, Darshan. Good to see you again.
Good to have you on. So, Sandeep, we're going to talk a little bit about this concept of decentralized care delivery and what is your role at Bluestream Health, and how does Bluestream Health sort of help with this?
Yeah, sure. So, prior to COVID, this whole concept of how you can get access to care when you're not sitting face to face with your doctor was kind of like telehealth or telemedicine, as it was known, right? Still has been around for a long time. And prior to COVID, it was kind of, being seen as a way of trying out some sort of means of, some patients may qualify, you've got to find certain requirements to get paid for doing video visits when you're not, with your patients face to face. So it was something that was used in limited use cases, right? So for example, behavioral health was one area that you could see this working really well. And there's been like tele-ICU, these programs that allow you to see patients remotely and help give advice and monitor them. And so when this big shift towards expanding, and in some cases, the only way of accessing care during the last year, because of safety reasons or not being able to see your doctor face to face because of the pandemic, it became overnight kind of like in terms of the percentages, right? What used to be 2 to 3% of all visits quickly became, some cases, 80, 90%, right? It was the way that doctors and patients were seeing each other. And so what that created was a quick kind of education, both for the doctors and patients for, first, is this doable? Can care actually be delivered? Can you request care and get access to care? And then on the provider side, learning what could be done, right? How can I take care of my patients? What are the scenarios? What are the use cases? How much can I do without having to actually, in some cases, physically examine my patients? So there was a big learning curve, but ultimately, it proved to be an effective way for care to continue to be, it may not have been perfect, but it allowed for those interactions to go on, right? So even though telehealth and telemedicine have been around for a long time, so what started to happen was these, accelerated learning started to take place, and then as this ecosystem started to get more familiar with how to do this whole idea of, decentralized care, which is the resources now for the people that are requesting care and the folks that are actually delivering the care, no longer have to be physically in the same space, right? That's kind of what this is. And then you layer on top of that the programs around remote patient monitoring, chronic care management, technology and using data for having insights that are coming to you from the patients and then acting on that information in a team-based approach with the patient in the middle is now feasible. And we've seen an explosion of companies now that are able to engage with their patients, and even not just for healthcare hospitals and clinics, but even pharma companies in terms of decentralized clinical trials and the ways now that they're looking for continuing to add value in a way where ease of access and also closing, that was all the good side, but also it exposed some of the gaps, right, in the digital divide, and some of the ways that communities that couldn't access care were also highlighted. So it's been a really interesting last 12 months.
It's funny you talk about the last 12 months. Yeah, absolutely. I think we exposed a lot of sort of open areas. You used the term as we were prepping for this conversation. You talked about this idea, and I love the term, digital front doors. What are the digital front doors?
Yeah, so traditionally it's been, if you wanted to see your doctor, you pick up the phone, call a doctor's office, and schedule a visit, right? So as the means of making that process more efficient, what became apparent is that if I'm a doctor, if I'm a patient, a caregiver, whomever that person is that has some sort of a need, you should be able to effectively go somewhere virtually, online, or physically, right? So those are all kind of points of access. So digital front door to care is essentially how I, as a health system or a clinic, I'm making my resources available to people that need my resources. So an example of that is New York City Health and Hospitals. During the peak of COVID, they actually created an online portal called expresscare.nyc, where the people in the New York City area now that couldn't go to see their doctor or couldn't get to the emergency room because they was being crowded by taking care of patients. So expresscare.nyc allowed anybody in the New York City area to navigate to this website, click a button that says talk to a doctor now, and within 30 seconds to a minute, be connected with someone that's going to help them deal with whatever issue that they were having. So it's the first time in the country, in New York City Health and Hospitals, the largest public health system in the country, was able to create this digital access to care. And so that's an example of a digital front door to care. And so similarly, you can have these not just for patients, but you can also have them as access points for providers as well. So think of nurses, caregivers. So if I happen to be a nurse, in an inpatient setting or in a home care setting or in a nursing home, acute care facility, long-term care center, if I have a patient that I need to get some help with, I should be able to, use my mobile device or my computer in the patient's office, and then click a button and be connected to the specialist who can then help me manage whatever I'm dealing with. So it effectively creates instant access to the experts that can help me as a consumer, help me as a patient, a caregiver, as well as a peer.
So if you're talking about this idea of, say, Express Care NYC, which I think is a brilliant idea, to be honest, do you think that as we enter into whatever version 3 of the pandemic, going to Delta, now talking about Lambda, do you see that learning curve has been addressed in so many ways? Do you see carryover? Because on one hand, I love the idea that, how should I put this? I love the idea that we'll be able to use these other tools, and now people are used to these other tools. Do you think that'll decrease the number of people who are going to the ER and therefore reducing the cost of care? But do hospitals then at the same time expect that they'll get paid the same as an ER visit, which seems unfair at the same time? So how do you sort of handle that? How do you handle the issues associated with that?
Yeah, it's a great question, right? And so the simple answer here is that everyone knows that more and more of these type of models are going to have to be adopted to reduce the overall cost of care. And so programs like Hospital at Home and other models that Medicare has been focused on in terms of reimbursements. So that's where the new remote patient monitoring comes in, the chronic care management programs, and this new idea of a hospital at home service So as a health system and hospital, you have to have the technology infrastructure, the resources to then have to adopt, right? So if you think about it, that improving access to care, it's not necessarily, so the program, the way it works, for example, the Express Care program, and some of the other partners that we're working with, is if somebody is reaching out to 911, you don't always have to transport that patient, right? So that's currently what happens. So when someone calls in, the ambulance takes the patient to the ER. What if you could actually help triage that patient virtually? And if they're not critical, help manage that patient with oversight, right? That's the ET3 program. So the emergency triage program that is now being piloted across, I think, 80 sites across the country. That's exactly what it does. If you have a paramedic at a patient's home, why not use them with the appropriate oversight to avoid that unnecessary transport, but still have a reimbursement mechanism that gets the payment models work so that the patient is taken care of, the person that's providing the oversight, it's all created as a payment model that's going to effectively avoid an unnecessary transport, but it also lowering that cost of care, because you're now able to instantly, create that digital front door of access for that paramedic to have a supervised encounter with an ED doctor, so that they're able to manage that patient as effectively as possible without having to transport them.
So it's interesting. I want to go back to that concept of digital front door, because I love the concept. What I'm hearing is at least 3 separate places the digital front door exists, and please feel free to add to that. But I can think of the ED, like you just mentioned. I can think of the emergency technicians, which quite honestly I hadn't even thought of. It's a brilliant idea. Like, why even bring the patient in if you can address the concern right there? But it goes to the training that the emergency technicians get, which I believe is something like 15 weeks. You'd have to obviously ramp that up quite considerably, so that they have the ability to provide the type of secondary advice, if you will, that if the patient doesn't come in, you wouldn't be able to provide. And then there's the pharmacist. So are there any others that you've seen use cases for, or conversations bandied about, that sort of talks about these other alternative digital front doors?
Yeah, so just think about it as three categories, right? And one is the consumer, you and I, patients. The next component to this are the provider teams, right? Anybody that's seeing or interacting with that patient in that care continuum, right? It could be a home health aide in the patient's home. It could be a caregiver. It could be a pharmacist who's trying to review medication and he needs to get in touch with the care team. So anybody that's involved in that care delivery chain is that next group. And then the other end of it is the inpatient nurses and doctors, primary care doctors who are trying to access specialists. So those are the large groups that you can create these digital front doors of access to experts.
So it's funny. So what I described as 3 opportunities, you've just described thousands.
Well, another good example is interpretation, right? So one of the tenets of Bluestream has always been embedding access to interpreters for example, deaf patients. So ASL, 200 languages. So those are all also digital front doors to care, because if you don't have medically trained interpreters able to join you in these sessions, there's a whole segment of the population that can't get access to these new care delivery models because they can't be in the office with the interpreter face to face with the doctor.
So how does it work in the context of when you're talking about allocating resources? You're now talking 100 more opportunities to meet the patient where they are. So when you're talking about allocation of resources, how do you decide, should we address the needs as we know them, or the needs as they probably possibly should be? As you are figuring this out and sort of galvanizing a whole new platform of engagement. So
no, I mean, that's a challenge, right? Because traditionally that's been done through scheduling, right? So I have to schedule an appointment, make an appointment for a specialty visit, make an appointment with the doctor, because that's how it typically works. Patients have to, either go online, find a schedule, find a spot that's open. But because of the disproportionate need for care and the number of people that can actually deliver that care, that's why you have long wait times, right? Because there's limited number of doctors, especially on the behavioral health, mental health side. There's a limited amount of people that are qualified to deliver this care. So that's why you have these long wait times. So and the way you can start to free up more time is, one, sorting through the needs, and the ones that need to be seen in person are the ones you go ahead and schedule for. But then the ones that don't necessarily have to be seen, but could be done, consults that could be done like you and I are doing this conversation right now virtually, if you can start segmenting those type of interactions. And then third is making sure you have, that's what Bluestream has, is that other component. I told you we have this patented provisioning engine. So as long as we know who your team members are, what their qualifications are, and their type of expertise, we can take care of that complexity. And so when your request comes in with a little bit of information up front, you can do that sorting, and within 30 seconds have you connected to the right person. So that's that last problem that we saw, which is taking your resources and making them available more efficiently.
So I love the concept of that, but it's one of those things that I almost worry for you guys. Like, how do you, the liability that you possibly take on with something like that starts to become
so
more
we're the technology. That's it. We don't actually, so we partner with health systems and hospitals that have these resources already. So we're not doing the care delivery itself. We are enabling providers who implement this solution to be able to use those existing resources efficiently.
But how you're using your proprietary prioritization engine, if you will?
Oh, no. I'm saying they do that, right? So you can, what I mean is, like, so you're not actually using an algorithm to prioritize. When that call comes in, it could be a triage nurse that's actually taking that call. And then once I determine what that level of service is, using Bluestream, I'd be able to do a warm handoff with the patient and the cardiologist, with the patient and the nurse practitioner. So it improves that efficiency of handing off. That it's a warm handoff. So you're not talking to a robot, you're actually talking to a human being, but that human being has the resources at their fingertips to then connect you with the right level of care for that next segment.
Now, which sounds amazing in principle, and I have two questions that come out of that, but let me ask the first one, which is the obvious one to me. I love the concept of, you know what, I make one phone call, one digital call, whatever you want to call this thing, and that'll connect me to the one person who can connect me to all these resources. The question is, what if the resource isn't available?
Yeah. So they actually, and so that's where we have our predictive models to tell you, as the health system, you set your service level agreement, right? Your threshold. I want these sessions or call requests to be handled within 30 seconds, 60 seconds, 90 seconds. So our predictive engine behind the scenes is giving you two choices. So we can tell you ahead of time, hey, guess what? 4 of your 5 cardiologists are engaged. If the next call comes in that requires a cardiologist, you're at risk for violating your SLA. So you have two choices: either bring on additional capacity, or you increase your response time. And then that's clearly displayed up front. So if I'm a patient who's trying to reach a doctor, I can see it's going to take me 30 seconds, 60 seconds, or 90 seconds. So as the system, I get to manage how I want that experience to be. Do I bring on additional capacity, or do I increase that potential wait time for that person to be available?
But that I love the opportunity to do that. But wouldn't that take a while for the hospital to go, turns out we have more of a need for cardiologists, so we need to hire someone? That's a 60, 90-day process. Do you have resources that can jump in almost immediately?
Yeah, and that's where a lot of these new companies that have started up right in the last year or so, there are now networks available. So you can actually, so this happens all the time for interpreting services, right, Darshan? So think about it. I may not have every interpreter that I need for any type of language, because I don't know if I need a Portuguese interpreter, a French interpreter, a Chinese interpreter. But our technology allows for seamless rollover. So if I use all of my existing internal resources for delivering interpretation, behind the scenes, you have existing contracts for overflow, right? So, hey, if I can't, help a Spanish patient because my Spanish interpreters are fully engaged, we know, because it's determined during implementation, that we hand off to an external network. So similarly, you can have relationships with groups of networks of providers, right? So companies like Wheel and others now that are building these virtual networks of providers. So I can have a contract in place that says, if I can't meet my required demand, then I'm going to tap into your network. So Bluestream manages that behind the scenes. So you don't have to go hire new people. You just have to have existing relationships in place that says, I'm going to tap into your bench of doctors if I need them.
So this is going to sound obvious for someone who's been doing this, but excuse my knowledge at the base level right now. But I can't imagine these highly trained doctors are sitting around waiting for the next phone call. So are these people walking around and they're just gonna, like, when they get a beep, they're gonna sit somewhere and just pick up their phone, or is it you just have teams sitting in rooms addressing questions?
Yeah, no, it's more simpler than that, right? So you set the level of availability. So, for example, you think of it in stages. So if everyone knows this idea of being on call or backup, right? So if my doctor's fully, engaged, then the next level up that we send these requests to is that doctor on call. If they happen to be fully engaged, then you have external networks that you can then access. So our engine looks at the current availability and response time. So it all goes into an algorithm that streamlines how you alert these doctors too. So if, for example, I may be available but not sitting in front of my computer logged in, so I can get a text message, email, or a phone call letting me know that, hey, you know what? Someone needs a cardiologist service. If you're free, hop on. Or we can blast it out to 200 people, and the first person that can take it can come into it. So there's different ways that you can escalate and expand the pool that you can access for making that person. It's all about making it as seamless and as efficient and as fast as possible for whomever needs that care.
So I have a question from someone, Ellen Bedenko. Insurance companies pretty much have been dictating how care is delivered in the US. I wonder if the insurance companies are now coming out with the guidelines regarding digital doors and digital care. And if yes, how do they align with the best clinical practices and patients' best interests?
Yeah, no, that's a great question. So there have been several health plans that are using our backend platform technology to help address improved access to the people that can actually help them, right? So if you have a concern, you should be able to reach whomever it is that's helping coordinate this care, a care navigator or a care coordinator. And in most cases, they can then help you connect to the person that's within your plan who is going to help you address this. And a lot of the health plans now are becoming more vertically integrated. So they have their own primary care groups, they have their own specialty groups. So having this seamless ability to have an encounter with your primary care doctor, who can then, instead of have to create another appointment or come back and see this, or here's a referral for specialty care, you can have this kind of care coordination aspect to this, right? So health plans, they're now more incentivized to make sure that they're able to deliver this care as quickly as possible and as efficiently as possible, because they have this thing called a medical loss ratio, right? So they are, the goal with that is whatever care delivery the premium plan members, right? Everyone pays a premium. Whatever those dollars that are not going towards the care of the patient, if you're below that ratio, that has to be returned back, to the plan member. So there's incentives in place to make sure that health plans are thinking holistically in terms of how to make that patient experience better.
But how does that work in the case of like capitated payment and the like, where it's you get one fixed fee for the type of work for the patient who's come in for a specific indication? How does medical loss ratios work?
Yeah, it's different, right? So Medicare Advantage is that's kind of the plan where you get a fixed amount for taking care of all of your patients. So in that case, this is a different model. So I was just talking the fee-for-service model, Darshan.
Got it. Okay, thank you. I know enough to be dangerous, so I'm glad you clarified that. Thank you. So we're now talking about building these teams. As you're setting this up, are you finding that clinicians are unprepared? I mean, obviously there was a big learning curve, but we still have people who haven't quite caught up to the curve. So my first question is, are you finding that there are people who are unprepared for this? And secondly, for the students, for the medical students, pharmacy students, nurses who are coming in, are they being prepared for this? And if so, what's happening?
Yeah, no, that's a great question. So I'll take the first one. So in terms of being prepared for these kind of new models. So the advantage that we provide to existing organizations is that you don't have to change what they're currently doing today. Meaning that workflow, right? It's all about efficient. When you introduce new methodologies, new technologies, that adoption curve is usually longer because you're changing what they currently do. But if you can keep that existing workflow in place and adopt your technology to what they're already doing, it's a faster adoption rate, right? So that's the first piece of advice is don't change how the doctors are getting to the patient. Meaning, like, if you want to introduce this, if there's a check-in process where there's a team member that checks the patient in, checks their vitals, updates their meds, and then in a physical clinic, then they're then taken back to the exam room. They wait for the doctor to come in. Doctor does their thing. They see a nurse or PA, and then there's a checkout process. So if you can try to keep as much of that's without me changing what I need to do, meaning the doctor isn't doing the intake, right? Because the way the appointment's scheduled in a virtual appointment, I can click a link and be with the patient right away. But that changes what I'm typically doing as the provider, where I'm not, I'm doing the intake and my job as evaluating what the patients need. If you can keep that workflow in place where a team member is doing the check-in, and then rather than walk the patient back, what if I could bring that doctor I'm scheduled to see seamlessly into a warm handoff in the video call so that the intake person does their part, brings the doctor onto their part, they drop off, the doctor and the patient connected. The doctor now can bring on a family member, bring in other resources into the call. So that's what we enable. And because it's done in a way that doesn't change what I'm used to doing today, it gets them comfortable to kind of adopt these new means. And as they get comfortable, they then start thinking through, wait a second, if we can do this, how could we do it for these other use cases? So that's usually what happens. We start with a simple use case, and then as they quickly get comfortable, the complexity starts increasing. So it goes from one workflow to that more complex workflow, and then finally you're doing multi-regional, large, distributed, you've got these multiple access to care, 4 different front doors of access. So that's where it starts. So you typically start, what the immediate pain point is and make the providers and the patients comfortable. And, fortunately, some of our clients have shared with us, they've done surveys of 150,000 doctors and patients after the consults are done. And providers, surprisingly, have given this, these kind of encounters, I think 97% have given them a 5-star above rating in terms of how this has helped them with their patients. And on the patient side, I believe it was 95% of patients gave them a 5-star above rating, and the rest were 4 or below. 4 or 5.
Wow.
So it's all about keeping it as minimally disruptive as possible to your existing workflow. So you're not changing what doctors are currently doing. You're just making that process more efficient for them.
But do you think that as we start getting these students who are currently students coming on and becoming actual providers, they should be trained differently?
Oh, yeah, there are. Yeah, there's been a couple of studies. A couple of my colleagues just released a paper that showed how that needs to change and what some of the gaps have been that future practitioners need in terms of training, right? So you heard this term website manner. It's about how you use these virtual consults and how do you engage with patients. So there's actually a technique, and those are now, I think, being incorporated, and hopefully it'll become more incorporated into your training as you go forward in the next couple of years.
I'm well beyond the time I usually allocate for our conversation, so I apologize, but I have to ask one last question before I let you go. Do you see a time in the near future where these digital doors are digital front doors? I love that term. The digital front doors are not just engagement via a EHR of some kind, and instead it's using tools like Siri and using tools like Alexa. I'm afraid to say that because mine will go off. But.
Yeah, I mean, look, it's it's already happening, right? So you have companies like Babylon, Ada, chatbots, right? So it doesn't matter how you're requesting access to that. It's knowing that you have the ability to get connected to someone, right? So it could be in a kiosk in a mall or a grocery store. It could be on your mobile phone. And that's where things are going, right? When you say decentralized access to care, it really is, right? You have these centers of excellence that are going around the country where, you can go to Cleveland Clinic for all your heart issues, or, fly down to Houston for your cancer. So that's kind of where things are going, where you're going to get these centers of excellence where everybody can get to, but you have access to that level of care pretty much anywhere you are. And so, so it is going to become, it's not going to, the means of how you get to that the care is not going to be limited. So you can be sitting in your car, driving. The car is driving you, right? You can get a consult while you're sitting in the car. It's just amazing. And think about it, right? In the aging population, you pretty soon you no longer have to go and sit in the doctor's office to have your exams, because you can actually have those resources come to you. So the companies like Circular and others are working on care at home. So it's already happening.
Which sounds great, but to me as a lawyer, that makes all my concerns around privacy sort of go, wait a second. These are like, I love the concept and the ease around getting my care in a grocery store or in a car. But what happened to my privacy? The reason I like my doctor's office was not just because my doctor was there, but because no one else was listening. And do I start losing that if I use a Siri and I know Apple's listening or Google's listening or whoever else is listening? So I just wonder how that plays out. I have to explore that with you at another time. I really want to explore clinical trials because you hinted at that, and I want to talk about what that could look like in the clinical trial world. And there's just more questions.
Yeah, and pharma in general too, right? Pharma has been watching for the last couple of years now, trying to understand how they can start playing a bigger role as more and more care becomes virtual.
As I'm sure it's not just virtual care, but decentralized care. I'm sure you heard that CVS announced that they want to do clinical research, which means they become decentralized pharmacies. What is the implication and the impact of that? So that's a whole other beast, and we'll tackle that when we talk soon. But Sandeep, thank you so much for coming on. I have 4 questions for you as we've discussed before. Based on what we've discussed, what would you like to ask the audience?
As you've been trying to implement virtual care programs, would love to hear what's been working, what challenges you're experiencing, and it's just been great to see and learn from a lot of there's a lot happening, and it's going to be interesting to see what programs are being. There's a lot of studies that are going on right now to kind of everyone can learn from together. So just would love to hear from how you implemented successful programs.
So I usually try to answer the question, at least to give my unvarnished opinion, to at least help start you off and to help other people sort of jump on. My answer would be I've been hesitant. I've been hesitant to use virtual care because I don't have a clear enough understanding of what the ramifications are for my insurance. So does my insurance, is it going to pay for all of it, or am I suddenly on the hook for it? And until I have my insurance, I'm a solo practitioner, so I worry that my insurance isn't as great as I'd want it to. And it gives me this breakdown of here are all the things you have, but it doesn't have a telehealth option in there. So having that explanation would have been really useful for me. I recently needed some healthcare help, and having that access, that information would be very, very useful. But that'd be my first response. My second question for you. What is something you've learned in the last month that you think our viewers would enjoy hearing?
Get vaccinated. It still surprises me that how many people are not, following the advice. And so, unfortunately, it's just what it is. But, every opportunity that, you have to kind of reinforce that. So, it's been a big, insightful understanding for, this whole understanding of the benefit of vaccines and why we should get them.
So I have a response to that, which I usually don't for most of these questions, but I do in this case. I just read yesterday, day before, that in the South, what they did to improve vaccination rates was they held a lottery, and I forget what the name for it was. And turns out they had like 100,000 more people getting vaccinated because they could play the lottery then. I just thought that was a brilliant idea. Like, it's truly meeting patients where they are, not where you want them to be. We tried the education thing, we're not getting very far. Here's the lottery, play it. It's great. And then I found out that Amazon's doing the same thing internally, where they're saying, if you get vaccinated, you can enroll for all of these other things you might win. I was like, that's brilliant.
Look, it's all about behavior change, right? So whatever incentives are out there, I think it's that's awesome.
Yeah. My third question, what's something that made you happy in the last week?
I guess getting our daughter ready to go off to college. So going shopping and So
where is she going?
New York City. She'll be in New York.
Oh, very, very cool. Congratulations to her. And Sandeep, the last one is actually something I usually ask, but it's available. How can people reach you?
I'm on LinkedIn. I'm on Twitter at Twitter at @spullum, and then it's just search for my name on LinkedIn. Thank you.
Awesome. Thank you so much again for coming on. This was wonderful as always. I hope we can have you on again soon.
I look forward to it. There's always something exciting talking to you about, so I look forward to it.
Thank you.